Hi, I want to welcome you all to our Wednesday Lunch and Learn session for the Primary Spine Provider Network. Today, we're extremely honored to have Dr. Matthew Devine, who I think you'll soon learn that his background has tremendous relevance to the issues that you're most concerned about and interested in. I'll give you a little bit of Matt's background, because I think he's too humble to tell you all this stuff himself. I had the opportunity of first meeting Matt way back when he was a first-year resident in family medicine at the University of Rochester, and I was a clinical instructor in that program, and we became fast friends subsequent to that. Oops. Okay, great. Yeah. He is a board-certified primary care physician in practice with the Unity Hospital Faculty Partners. Matt is a regional dean for the Lake Erie College of Osteopathic Medicine. He's the current president of the Monroe County Medical Society. He served on multiple community guidelines for asthma, diabetes, back pain, quality improvement, hypertension. He is also board certified in osteopathic manipulative therapies and has received advanced training in buprenorphine use for opioid dependence. So he's got a really extensive background in this whole field of spine care. And with his background as a clinician, as an educator, as a policymaker, I think we're in for an exciting hour of discussion. So welcome, Matt.
Thank you, John. It's so good to see you again. It's been a while. And,
I know.
I was reflecting on my time when we first met now, 17, 18 years ago. So it was,
oh my gosh.
time has gone by,
Oh, absolutely. I was shocked when I looked back of when you were a resident. That was 17, 18 years ago. And I thought, oh my gosh, where did it all go? So I'm going to jump right in. There was information that was transmitted to us from a physician, Craig Samet. Craig, primary care doc, he was the CEO of Blue Cross Blue Shield of Minnesota. And prior to that, he was the CMO of a large accountable care organization, I think in the same area of the Midwest. In any event, Craig reported data at a conference he gave at Harvard that from their own internal data, only 6% of their costs went to pay primary care physicians. So for direct costs to pay for primary care was only 6% of their budget. However, they determined that 80% of the remaining 94% of costs were directly related to where the primary care physicians sent those patients. So primary care therefore accounted for roughly 3/4 of all costs by virtue of what they did or where they sent the patient. So that's why it's what we can learn from you today is so important in getting a handle on how we can improve spine care and healthcare in general. So let's talk a little bit about, we all know what a major problem healthcare, spine care is, 90 billion in direct costs, at least that much in indirect costs, which is disability and impairment, wide variation in care, and opioid crisis. So the first thing I'd like to ask you about is decision-making relative to spine patients. So when a back pain patient, a neck pain patient shows up in your practice, how you think about what to do with them. And I'm going to put you on the spot here and ask you to give us 3 perspectives, because I think you're involved enough in your community to understand it from all 3 perspectives. First, your own perspective of how you make the decision. Secondly, from a medical student or resident's perspective, how adequately trained are they to make these kinds of musculoskeletal decisions? And then from the average PCP in the community, knowing you can't speak for them, but you have a sense, given your administrative role, of how they work and think. So that's a lot to bite off, but
No, I actually was thinking about this very same breakdown sort of on my way from my other office to here, saying the audience does not want to hear about me and what I would do with all of these patients. They want to hear about the residents, the students, and the other PCPs that I can fill in the gaps for. And the reason that they don't want to hear from me is because I've done so much work with you and Brian and other people where I should be able to regurgitate the right answers based on that. And I think 95% of the time, I teach that and train that. And so I'll obviously just start with that as a very brief sort of overview. So, for general spine care, I think the biggest, most important facet of a primary care physician is really meeting the patient where they are, establishing a relationship with them, trying to, look under the hood, so to speak, as to what are some of those other important barriers or problems that they're having that play into that picture. So, as a family physician trained, there's a big part of me that wants to kind of know where they're coming from, what is this aspect, how's this, regardless of the problem, how's it affecting your life, how's your function, what things are missing from that. And then I think obviously from there, when we talk about, back pain in particular, it's that active lifestyle. It's really trying to, make sure that there are none of those red flags, which thankfully those are fairly, they're common, but they're fairly uncommonly common, right?
Yeah.
So they
Yeah.
don't happen as much. So you have time to wait, for imaging, and you can kind of think about manipulation. We can think about physical therapy. We can think about other aspects of care before we get neurosurgery, MRIs. We can, even use our chiropractic colleagues and friends to kind of help with that. And so taking a step back from that, even though I've been able to tell you what the approach should be, I'm here to also say that doesn't always happen with my students, with my residents, with other PCPs, right? So I think the word of continuing that educational piece has been one that we, myself included, and our systems have felt to be really important, right? There's costs that are associated with wasted imaging. The insurance companies don't want to pay for imaging if it's not necessary. Neurosurgery doesn't even want to see a patient unless they have an image. So you need a reason to order the image, and you shouldn't just order it to order it. And then on top of that, physical therapy, potentially even chiropractic care do kind of have some of those co-pays that are different because you're frequently seeing them more often than you would be seeing another specialist. So there's costs downstream to the patient. And of course, there are medications that are out there, but, for acute flares, they can be more helpful. But for, subacute to chronic stuff, trying to limit those is important. So I will say on record, and it's already known, that PCPs could be doing better with their care, and how to improve that is to do exactly what you guys have been trying to do over the last many years. COVID probably didn't help. That is further education, really kind of helping to update them by way of continuing medical education, lectures, grand rounds, and obviously the future physicians, like the residents and students, they're still actively involved in education and learning. So we have them, hostage, so to speak. So they have to show up to a lot of these things. So, for me, it's been one where the transition's been nice because I'm focusing on people that are still wanting to learn, have things to learn. And it's not that PCPs don't want to learn. It's just that they have so much other stuff on their plate, as you talked about, with the weight of healthcare sort of sitting on their shoulders.
Yeah, absolutely. There's one, I recently stepped off as a board member of the United States Bone and Joint Initiative. And one of our board members, Bruce Browner, who's an orthopedic surgeon at Duke, got a program going called MSK Education for medical students. And it's for third and fourth year med students. And in fact, it's not fully finished yet, but he's just reinvigorated the program. It's for third and fourth year medical students who are going into primary care to try to enhance their musculoskeletal education, because it's such a common complaint that they're going to see in primary care. And, and the sense was, the whole point for Bruce getting this program going, which was actually started by another orthopedic surgeon, Joe Bernstein there. Is it still your take that MSK, would you agree with him that MSK training through medical school is lacking?
Yeah, great question. Obviously, I think the answer is yes. And I'll say twofold. I mean, I came from a family medicine residency that was allopathic. So, I was training, majority MDs, but there were some DOs in the program in family medicine. And so I found that that's where I could really tap into your question more, because as an osteopathic curriculum, we almost were hit, you couldn't get away from it in a lot of ways in my first and second year. And then obviously third and fourth year, you're not seeing the laboratory work and some of that other kind of hands-on work. And it just depends on the interest and talent of the student then to continue that skill set. So majority that I'm even working with now that are osteopathic medical students, they can tap into that first and second year. But when you're talking about the allopathic MD students, oftentimes it either didn't get taught or it got taught and just didn't get that repetition that I think is truly needed for something like this to kind of let it stick. And then obviously to hit the real world and apply those with real patients that are sitting in front of you, and not just standardized patients or textbooks or lectures or PowerPoints. You have to actually do the work, do the exam, and kind of think through that a little bit more. And so I applaud your colleague for working on that. I'd love to see sort of what that curriculum looks like. I could imagine even the osteopathic students could use that as well, right? I mean,
yeah. Do you find throughout? Yeah, I know you've been in practice for 16, 17 years. Do you find you use the manual therapy training you received in osteopathic school in practice quite a bit? I mean, certainly diagnostically, but do you use it therapeutically at all?
Yes. So I would say back to my comment of the interest versus talent of an individual is really important coming into this. So I was very pro osteopathic manipulation, manual medicine. Those were the only schools I applied to. I gravitated to the philosophy. I liked it. I even, applied for the manual medicine fellowship in the first year of my schooling and didn't get it. It was that competitive. They wouldn't let me in. And it was okay because I spent, a couple of months in my third and fourth year doing manual medicine electives through mentors of mine that had been in Philadelphia. And then when I got to my intern year, as a disclosure, I had a horrible ski accident in my second going into third year of medical school. So I had a bad tibia plateau fracture and every ligament in my knee was destroyed. So I had to have 3 surgeries and was on crutches for 3 months. And it was just this disastrous event. But throughout that time, I did radiology, so you could sit down for a month. I worked with my orthopedic surgeon who would let me sit in the OR and let me go over to PT during work. And then I worked with folks doing OMM or osteopathic manipulation, and they there's ways that you need to conserve your body, as you all know on the call, that if you're doing workouts every day by working with patients, so there's ways that you have to kind of figure out
Yeah.
how not to totally, walk home and can't get out of bed the next morning because you have to do this again. And that sort of taught me, hey, I'm rehabbing something, but you can still do this care. And so by the time it came to figuring out what I wanted to be when I grew up, I did an internship, traditional year internship, and that program mandated that we take the national and osteopathic manipulation manual exam, and they paid for it, and they gave us quarterly lectures. So I had a little bit different of a track because I liked it. My program mandated it, and I used it all the way through my first 5 years of practice. And then I got to a place that was all allopathic, and people were like, sure, you can use it. In fact, can I come in and watch you? Because I don't know what this is. And like, I am precepting you, but I want to make sure that I see this, not because I don't think you're not doing it right, but because I want to know how to do it.
Yeah, interesting, fascinating. I do want to tell our audience, right now at 1 o'clock, we'll open it up to questions from everybody. But right now, if you do have a question, you can type it in the Q&A that should be in the bottom toolbar on your Zoom webinar screen. So feel free to please type in questions right now if you have them. Matt, I'd like to ask your thoughts on this idea too, and that is, if you get, as a primary care physician and you're in private practice and you get contacted by a chiropractor or a physical therapist out in the field who is saying, gee, I'd like you to, when you have a spine, a musculoskeletal patient, refer to me. What influences you positively and what influences you negatively? What would influence you positively about one of those providers contacting you saying, gee, I'd like you to use me as a referral source?
Right. Great question. I think, for that piece, my answer is trying to find the best fit for the patient is always my number one feeling or thinking when I'm doing a referral. And the referrals that I tend to gravitate to are to offices that have, at when all possible, sort of one-to-one therapy or care. And so, as you know, there's different models that people need to keep the lights on. But I really try to utilize both physical therapy and chiropractic offices where, that appointment time is slotted for you, and there isn't 2, 3, 4, 5 other people sitting there. It's sort of more common in the physical therapy arena than I think in the chiropractic one. But that's a big one for me because I find that, as you know, most patients don't do their homework. They don't do their home exercises. They don't do their stretches. And there's downtime, I think, in PT and even in the chiropractor's office. You need them to sort of warm up and stem them and some of that stuff, where I get that there's time that the practitioner doesn't need to be in there. But I really want them to have that value add of, I worked intensively on whatever it was that I worked on, even though there's homework to be done. I want them to have the biggest experience for their copay, for their value, knowing that we're all human and the phone rings and we have to make dinner and the laundry needs to be done, and those things happen that just, quite frankly, I'm a bad patient myself. Like I've had a nice series of being in physical therapy, and it's like, I can tell you, my daughter, it surprises me because she does everything that her, she's a runner, so she's had this physical therapist that has told her stuff, and she does it, and I'm like, you're the only person I've ever met that does this. It's like flossing your teeth, like you floss them the week before the dentist, you have the dentist, and then you stop doing it, or maybe some do it every day, but it's not super common for people to be able to do that, is my point. So when I'm thinking of referrals, I'm thinking of how can they get that? And then, and then it comes back to that relationship, that I want them to build a relationship with their therapist of trust. And I want there to, we don't always meet and mesh, right? I mean, that's okay. We have different opinions and thoughts, and people come from different spaces and places. So I'm always trying to like make a match, so to speak, with, people and so for me, the biggest important thing is that face-to-face, or trying to really get a sense of what it is your office is doing, what you want to focus on, and trying to make even a Zoom or a quick, before, patients start in the morning or at lunch, probably not at the end of the day, that's a bad time to sort of meet, just so that people can like see, what your practice is, where it is, location's also a helpful thing. And then obviously I think from there, that'll help kind of push things in that direction, because it's like, okay, well, this person obviously wants to work with us and wants to work with my patients. They're here. They seem nice, but there's 15 other choices, but why not try this choice and kind of see? And then I'm always asking my patients, like, how was that? Tell me about it. How did you feel? How did the practice run? How much, did you feel like you were waiting, and all those things? I'll ask them, because they'll tell me, like, right? I mean, that's part of that conversation. So we are constantly trying to hone in on people being able to get in quickly, and having a good experience with that.
Yeah. Hey, yeah, you came from the University of Rochester, and where the biopsychosocial model of healthcare started, and Highland Hospital, where you had Howard Beckman, Tony Suckman, Ron Epstein, who are all relationship-centered care physicians. So yeah, you had a great background.
It was beaten into me. Over and over. But now I see that the fruits of that, right? I think there is that it's a real thing. And the fact is that there was 6 months of my residency spent on just psychosocial medicine. And
that's phenomenal.
It's something that you would never take the time to do, but it was part of the program, so I had to do it. And at the time, I actually liked it. I came to the program because of that. But back to the point is, I think it's really very much helpful in just trying to peel away at the onion. I mean, every patient is so complex, and some, as you know, don't even want to get better, and some can't get better. There's such a mind-body piece to all of this, and it's trying to figure out, do I send them to John? Because if they're not even really willing or able or wanting to get better, then I don't want to waste your time the same as theirs, right? So it is that difficult scenario.
Yeah. Which I'll this is a loaded question in terms of, we could spend a week talking about it, but given your background with policy and administrative role too, how do you see the shift from fee-for-service to value-based care, where you're starting, where the system eventually rewards? Well, here's the biggest thing we hear with primary care, that they're overwhelmed in practice. I mean, there are so many demands on primary care physicians from every direction, that your time is your most valuable commodity as a primary care physician, and so since you're already overwhelmed, it's hard to ask primary care docs to do one more thing, or take one more course, or use one more tool that might help you in practice. But and then secondly, all these things that you're talking about take time in practice, right? If you're going to do some psychosocial assessment of a patient, it's going to take you time. And that's the last thing you probably have as a primary care physician. And the system yet fully doesn't reward that, because it's fee for service. You can make more doing a 5-minute procedure than taking 20 minutes to talk to a patient. How do you as a primary care physician think about that or deal with that?
Right. Well, I think the way that I think about it, or deal with it, has been answered because I've worked in training practices where I can have a little bit more time, because I have such a tremendous respect for my colleagues who are in private practice or, practices that are even employed that are patients every single day of the week, right? And so
Yeah.
the issue then, back to your point, is, we are in this middle point of this kind of fee for service to the value-based, thing. We haven't kind of flipped the page on that. There's still this kind of, dipping our toe in the water and doing these little kind of contracts with some of the insurers or other, folks around. But ultimately, for that value-based piece to work, you're going to have to probably see less patients, right? And so there has to be a shift in that sort of amount of the fee or the quality, or not the quality, the quantity of patients has to sort of go down for the quality to go up. And back to your point is I think we're at a point now where wellness is not good across, not only hospital systems, but amongst specifically primary care. And I think it has a lot to do with this one more thing, because it's like you're tacking on their mammogram, their colon cancer screening, their microalbumin, their A1Cs, all these other things. But it's good for quality, but the quantity is still the expectation. They're still seeing as many patients. So I find that until we really flip the table in the sense that both the hospital systems and the insurers say, okay, we are going to go all in on this, we're going to continue to kind of almost frustrate the primary care folks, because it's just putting more on the plate. Nothing's coming off of it right now.
Yeah, I thank you for that insight. Yeah, it seems to be quite quite true. There were a couple questions typed in. I'll ask you. Ben asked, when choosing a provider to refer to, what things would make you choose between referring to a PT versus a Chiro for a condition?
Yeah, so I think and you guys can fill me in. You can teach me today. I mean, there are a couple physical therapists that are in town specifically with me that have been trained in McKenzie technique, and I found that to be extremely helpful. They had some head and neck specialized training, so for headaches, cervical neck problems, whiplash injuries, maybe even some thoracic stuff. I really gravitated towards them because I know it's a one-stop shop and they can even do some of that cranial medicine as well. For chiropractors, again, thanks to my program, I'll be the first one to admit that when I first came to Rochester, I was like, well, why would I want to work at a chiropractor office? I already know all this stuff. What am I doing? And I'm so happy that I met John and Brian, and since then, Eric Perlman, Jen Spitzer. There's some of these other folks that have sort of come into my worldview that I am so appreciative and in need of your guys' services, because you guys can do this work all day long, right? Even as a primary care doctor in a teaching facility, I can't get everybody on the table and treat them the way that you guys are able to do that day in and day out with the efficiency that you do. So I think for me, that referral has been through those relationships that I've built with the specialists that are in town, and then the communication, that kind of back and forth, where I don't really care much about the medicalese progress note. I care more about, is this helping or not? And I think that's mostly what the primary care docs would like too, because I still even have a hard time reading what the physical therapist is trying to say. Even what you guys are trying to say. We have sort of different ways to redocument stuff, and it's like, are they getting better? Is this working? What's the plan? Where are we going? And that's sort of all that I need to know. And that can usually be, I don't know if there's a quick way that you can put that at the end of those notes so that people will just be like, yeah, this is good and not good, or here we go.
I'll give you a real quick anecdote in this, man. This was way back when Brian and I started in practice. And We used to, when we were getting referrals from primary care docs, we would write a 2.5, 3-page narrative and send it back to the primary care doc. And we finally had the good sense to survey a bunch of the primary care docs who were referring as patients and saying, what do you think of our reports? And they all said just what you did. I don't need a 3-page report. Couple paragraphs. What's wrong? What'd you do? What are you expecting to, the outcome to be? And that's it. So I understand that. Let me jump to another question that Dan wrote. And again, with your work with the organized healthcare system, like the University of Rochester, Rochester Regional Health, hospital systems are disincentivizing any referral outside of their system. They don't want leakage. So I guess this would pertain more to physical therapy than chiropractic, because typically chiropractors are not part of the healthcare systems, right? So if you were to refer to a chiropractor who's not in the system, it wouldn't be attributed back to you as a referral outside the system, or would it? Or would they say, we want you to refer to a physical therapist who's part of our system?
Yeah.
And thank you for the question, Dan.
Monroe County majority, because that's sort of my, and Dan, this is something that I know a lot about. So I could talk a lot about leakage for a while because of my work in the accountable care organization that was in town. But essentially, to answer your question is, I'm sorry, you've created these relationships with people that should still be able to be used, and the patients that you've seen should still be able to come in and see you. Even in my work, when we were trying to focus in and try to keep everything in house, so to speak, we didn't want to go outside and say, if you've been seeing Dan for the last 30 years, that you can't see Dan anymore. You should still be able to see Dan. But for new referrals, we were trying to sort of pull them back into the network when possible. But I think that just comes back to that clinician should be able to refer to who they want, who they've worked with, who they've had good experiences with, regardless of where they are in a system or not in a system. And then obviously, if it's possible, and if you want, it'd be great for you to get affiliated with the system so that this problem doesn't occur. But I know that that's probably even another headache or another issue altogether that is real. So, I guess for me, the whole point is that this is the part where I think we're getting it wrong in some states, because the fact is that Dan is doing really good cost saving work, and you could send them to the person that's the affiliated person, and they could be spending double, triple the amount of money on the care. That's no good, right? That's not like that. How's that saving any money for anyone or any system? So I've seen that sort of time and time again, and more with the physical therapy than with chiropractic. But I've seen chiropractic just not being part of these, part of the ACOs, which is like, what is that? Like, why is that a problem? Why wouldn't you guys be part of this? And that's always been my headache and my frustration with how it is locally, at least.
Yeah, that's part of the work we're doing in working with ACOs and our spine care partners work is to try to get them to develop relationships with pathway trained chiropractors in their community. There's a question from Stephen, who practices in the north side of Chicago, saying he's seen a lot of patients who don't have a PCP. They're using urgent care. Has that been your experience too?
Yeah, so there is a huge shortage of PCPs taking new patients. And so with the bore out of urgent cares, with their really growth with COVID, I mean, that's where people were going to get their COVID tests, and lots of offices were shut down, and et cetera. So the problem right now really has to do with that workplace sort of shortage. And obviously, I think he's coming from Chicago. I'm sure it's pretty much the same across the country where there's just, you know, people are opening their practices and they're full before they even expected it. And there's only so many patients, obviously, we can see. You know, I think the full-time equivalent for a primary care doctor in our region is around 1,700 patients on a panel. Now would be seeing patients, you know, four days a week, 4.5 days a week. And that's that's technically a lot of patients, but there's a lot more people that need to be seen as opposed to primary care docs. And then there are people that are retiring early now and sick of it and done with it. And so I think this kind of continuing to try to create incentives, both with, you know, loan repayment for primary care and other things, because let's face it, some of the other specialties do end up paying a bigger paycheck. And so people then, when they get done with school, they're like, well, why would I go and be a family doc when I could be a anesthesiologist and work 3 days a week and make double, you know? And that's sort of what they're deciding to do. And I don't know how happy they are, but they don't have, they should be able to pay off their bills a little bit quicker for sure.
Yeah, I'd like to open it up to those who are panelists here today. To feel free to unmute yourself if you have a question you'd like to ask. And we'll let people go at 1:15, but we've asked Matt to stay on to 1:30 so that we can continue. So is there anybody on the panelist side who would like to unmute themselves and ask a question?
Sure,
David,
Matt.
Oh, go right ahead.
This is Austin McMillan. I'm a chiropractor in the Seattle area. I appreciate your time and commentary today. This is a super important issue, I think, for us trying to open up referrals. But given that time is the most valuable commodity, and primary care is kind of overwhelmed, and also oftentimes I guess undereducated on MSK or SRDs. What do you see as the most convenient kind of relationship pathway? Is it a personal visit? Is it the note that comes in that's brief? Is it some type of continuing education that might improve their caliber of examining the patient? I mean, what is it that you would personally engage, or see somebody that maybe doesn't have your expertise engage to try and build that relationship, which is the thing that I'm after in my practice?
Right. Great question. I would answer it by saying, you know, I think it's a combination of all of those things that you talked about, you know, as within reason, knowing that these things are difficult. So, you know, having meeting them or trying to get some updated educational pathways at, say, their grand rounds, or if they have any primary care consortiums or meetings or things like that, where they're we're all required to continue to learn. That's a place to go. Obviously, when you do see patients, of continuing to, you know, get back in touch with the PCP's office with notes that are quite readable, with that, you know, with that one little summary statement up the top, and then for your billing reasons, you can write all the other stuff that are important to you guys for sure. And then obviously that personal relationship, I think, would be helpful. I think that's only a one time or every couple of years type of thing, where I don't think it has to, you know, be much more than even just a quick phone call after sort of you've met. Or now with Zoom, there's lots of ways that we can kind of see each other a little bit easier before our day starts or in the middle of it. And I think obviously the big thing, back to your point, is you know, the fact of the matter is that we have to continue to have people remind us, because especially as a primary care doc, even though folks aren't good at MSK, they're seeing such a breadth of stuff throughout a day. But things do tend to come in bunches for whatever reason. So when stuff starts kind of funneling through and there keeps having back pain after back pain. Maybe it's because the weather's changing and they're out in their gardens and there's more, people that are sort of weekend warriors than there were before. Then, those are chances to sort of pick up that care. And when you're seeing that in the community or just seeing some of that, those things change, those are the times where kind of being that kind of squeaky wheel really sort of helps to kind of continue the flow back through the office, and or any scholarly activities or any ways to sort of get folks involved in collaboration are other ways that I think could be another thing that could be helpful. And that's another time commitment, but it often is fun. Those are fun activities for, all of us alike that kind of do this work to try to kind of put some other spin on it and another way to kind of share our learnings or learn about what we do.
Jason, we have another question. Jason Conley.
Hi, you can hear me?
Yeah, we hear you great.
Thank you for having me. My name is Jason Conley. I'm a physical therapist in Southern California with Kaiser Permanente. And so my question for you and the physicians that may be on the panel here are, what is the role, or how do you guys view the role of physical therapists who complete postgraduate residency and fellowship program training? And how does that influence your decision making to refer out to practitioners who have that additional level of training as opposed to just con ed stuff? Because I work in a very isolated system with Kaiser, so I kind of know what my doctors are here like, but I'm kind of isolated from the community at large the last 15 years, and curious to your opinions of how you view physical therapists who go through postgraduate residency and fellowship training and your influence in working with those practitioners.
Right. Yeah. Jason, thanks for the comment. And there's oftentimes that I'll say it here and I'll say it again. I'm jealous of a lot of things that Kaiser has in regards to just the efficiency and the collaboration and communication. But stepping outside of that, as you mentioned, those are things that PCPs and physicians need to be educated on, because most folks probably don't even know or think to ask or would understand that a physical therapist could have done additional training sort of after their typical educational pathway. And so I think back to your point is, if they knew that, and if they would definitely understand that, they would appreciate that and would rather send folks to that individual than others, because that's something that is an investment that folks have taken in their careers and in their care for patients that I think speaks volumes that would be helpful. But if nobody knows that there's that's happened, then they kind of enter the queue like everybody else, and the ways that referrals are set up now don't differentiate that. So how to really get that information out, I think is probably has to deal with that sort of relationship building and getting on the circuit of doing some grand rounds and really highlighting that even in the beginning of saying this is what the typical educational pathway looks like, but this is what I have or what we have that we can offer separate to that.
Appreciate that. Thank you.
Yeah, thanks. Austin, you want to?
Kind of a follow-up question to that would be, what maybe are the 2 or 3 things that you personally would want to hear to have you refer to a primary spine practitioner versus just a general PT or DC?
Yeah, thanks, Austin, for that question. So for me, because I know a little, I think I kind of know a moderate amount of what you guys do. I'd want to know what services that you guys are, utilizing within what modalities you're able to use or are using, for that matter, because I think there are a fair amount of modalities that are out there that some folks, do them all, some kind of zone in on them. So if there's any particular, I guess, areas of interest or areas that your practice does better or you feel has better outcomes with patients than, say, some of your other colleagues, those are things that I would gravitate towards all day long, because I think now in this day of gathering data and kind of using it you guys can use that to your advantage. And with that, you know, I know that there are lots of things that do sort of come up that still aren't always evidence-based, or the evidence is still being worked on. And it's okay if that's something that you're imparting in your practice and you're anecdotally having good results with. But being able to speak to that, because more and more, especially with my allopathic peers, they always want to know what the evidence is for things and where things stand. And so being able to sort of back that up, and if you can't, it's okay to just be like, hey, I don't have you know, an article on this, but I've been doing it for 2 years, and these are my outcomes of the patients that I've been working with. You know, doing your own little quality improvement, you know, project, I think will sort of bode well for referrals, and then for, obviously, ultimately it's the patients, right? That's what we're sending the patients to you for hopes of improvement. And we all know that we can't fix everyone, but you guys do a darn good job of fixing folks. And I think tooting your own horn is okay, and in a way of trying to let us know what it is that you offer and can share with us as we go forward.
Oops, we did have Goodman, who is an attendee. I think we lost him. Are you still there? Oh yeah, great. Goodman, if you would unmute yourself. You should be able to ask your question. Oop. But I do see you're muted. I don't know, David, do I need to promote him?
No,
the
he must be off camera, off screen.
Okay,
Can move on.
yeah, I see
Jason.
he's still muted. Okay, sorry.
Go ahead, Jason.
So
Jason, you go ahead.
you just brought up a good question, and again, right, I'm always curious to now the roles outside, and especially on the other side of the country, right? We have people from over here. What is the primary care practitioners role, PCPs opinion on passive modality, passive care as opposed to active care, in terms of, you just brought up this idea of different modalities and the evidence related to, right, you know, successful outcomes where modalities may give short-term pain relief but really aren't necessarily valuable long-term, and how you guys value and view those options within the rehab practice and their usefulness, as opposed to maybe what current evidence is saying at this point.
Yeah, that's a really great question. You know, I think, you know, obviously looking for sort of a balance, where, you know, we want the patients to be able to do as much as they can to help themselves to fix themselves. But there are certain times, as we all know, that, you know, we can assist with the body kind of doing that recovery or that next step. And so for me, you know, if there is a technique or a opportunity that you have found success with, well, of course, that can sort of jumpstart things. You know, it's like, I'm sure you guys said this to people millions of times. It's like, you know, your body from this car accident is going to eventually get better, most likely on its own if I did nothing. But if I do something now, kind of correcting some of these dysfunctions that are here, then guess what? Like, you'll get better quicker, faster, and you'll sort of get back to work and get back to life as you know it. So I sort of use that same premise within some of the other conditions. And it's hard because, as you guys know, if we could, you know, for me as a primary care doc, I'm often getting the chronic, this has been a problem for a long time. And it's like, I'm really not going to be, I don't feel confident I'm going to be successful in getting them better with this. And they've been all over everywhere. And so, you know, it's one of those where the sooner we can get them into care and create and fix some of those dysfunctions, and then create that kind of active lifestyle and coaching and getting them moving again, that is critical, right? And so hopefully you guys are seeing a lot more acute care than I've been seeing in my, you know, career. But, you know, being at my practices, they're like, oh, Matt's a DO, I'm going to send them this patient to do OMT. And it's like, Well, they injured it in 1984. And so good luck with me to try to fix it from, the last however many years it's been, right? So that's one where I'm like, please send me like the sports injuries and the NBAs and the, tripping off the curb, last weekend. Those are the ones that I can actually feel good about, that I can fix quicker. The other ones, it's almost like it just gets them out of the office to be a headache for somebody else for a little bit.
Goodman, I think you can ask your question now.
Yes. Hello, Dr. Devine and Ventura. So yeah, I'm currently here in South Africa. The challenges that we face here, there is this stigma about chiropractic, and when it comes to knowledge about let's say on what we provide, on what we can do for the people generally they are not aware of our services. It's different to the to the way it is there in America. So I feel like we need to have more public awareness when it comes to what we provide, because I've seen some stroke patients where I've learned a lot when I was seeing those patients, and I was surprised because normally once the your medical aid is exhausted, normally the hospitals here, they will just dump those people like, okay, go home now. I was really touched on how people are getting treated there, though they are not aware on what can provide. So for me, I feel like we need more public awareness in this area. But the thing is, how can we let the public know? Because the way we are supposed to market ourselves, you can't really market yourself on what you provide. So that's the main challenge that we have this side, guys. Yeah, thank you.
Yeah.
Thanks, Goodman.
Thank you for joining us today. It's great to be hearing from South Africa. I think there probably is a great difference. Maybe you could be the next speaker, because I'd love to hear about the how things look in your part of the world. But to try to answer the question for you without obviously knowing everything there's to know about where you're coming from and some of those other hurdles that you have to go through is, I think for social community education now, there are lots of different opportunities out there that I only really am familiar with because I have kids. So there's Instagram, there's TikTok, there's you name it, social media where those YouTube and other things where I think you can sort of build some of these platforms without breaking HIPAA violations to try to get some quick, easy education out there, using QR codes and a billboard, doing some other opportunities like that where it can really help drum up education, and kind of sharing that kind of word is a possibility. But of course, it takes time. It takes a little bit of talent, and it takes, a little bit of luck to sort of, hit that and get it running. But I think those are some thoughts that quickly come to mind to me of kind of trying to figure out how to get that word out there, because people aren't reading newspapers like they were before. They're not, they're watching all different types of television with different ways that they get their television. So the commercials aren't all the same and things like that. So I think trying to think about those other resources of how to spread that word is an idea, as an option.
Yeah, that's wonderful.
Having practiced for 10, I'll give a very brief comment on that. Having practiced as a chiropractor for 10 years in South Africa, a little bit of feedback from my side would be really getting back to what Dr. Devine said, Goodman, in terms of development of relationships with individual specialists or doctors. Pick one or two neurologists, neurosurgeons, and family doctors, and build the relationship with that individual. And that it's a kind of like a concentric rings of a ripple in a pond. That effect tends to have a recurring revenue effect on your reputation and the public awareness of the kind of services that PTs and chiros can bring.
Mhm.
Great.
Yeah, great. And David, I apologize. I was remiss that I didn't stop at 1 p.m. to let you just make a brief mention about, joining Primary Spine Provider Network. So if you want to do that right now in the last 2 minutes.
Yeah, thank you, John. Thank you, Dr. Devine, for your time. It's much appreciated. It's been a very stimulating conversation. I'm just going to briefly share my screen and show you guys what the PSPN offers. So the Primary Spine Provider Network is a membership community platform that equips you as a primary spine practitioner with the tools and resources to advance your skills, reputation, and career. And there's several features of the PSPN, which we'd like to run through briefly with you. First of all, you get access to a training workshop. So a 3-hour training workshop that covers essentially the high points and most important elements of primary spine care. We also have virtual grand rounds. So that would be this kind of environment that we will have an expert in some domain of spine or some specialty, and we'll bring them onto our live webinars, and you'll have access to that. And then there's also other features and resources like tools that you can download, PDFs, even some of the things that we're working on redeveloping now, which would be template letters that you can use to send to a primary care practitioner or a GP. So that will be accessible as a member on the PSPN. Some of the benefits is that of your monthly membership fee, which is $8 a month, $1 of that goes to World Spine Care. So you're helping people in underserved regions get dire care that they need for managing chronic back pain. And there's Scott Helderman with some folks that are involved in one of the projects in the Indigenous peoples of Canada. So sign up today, no contracts, instant access, and a money-back guarantee. That's the link there. We'll put that in the chat for you. John, over to you.
Thanks so much. Just to let Matt know, World Spine Care was started by Scott Haldeman. Scott's a DC, MD, PhD, and practiced the majority of his career as a neurologist out in California. And he started World Spine Care. He's from South Africa also, by the way, Scott, originally. And started World Spine Care to bring first-class spine care, everything from conservative primary spine care to surgery, to the most underserved parts of the world. So they have in South Africa, they have clinics. They have them in Mumbai, India. They have them in the Dominican Republic. They have them in the outer areas in Canada, where people wouldn't be able to avail themselves of spine care, and it's all free. And so they have free clinicians, surgeons, physical medicine and rehab, chiropractors. I don't know if they have physical therapists, but they might. But it's just an incredible organization. So we take, we only charge $8 per member per month, and we take $1 per member per month and donate it directly to World Spine Care. So it's an incredible program. But I apologize for the background noise. They're doing yard work down here in Florida. But Matt, I just can't thank you enough. And it's so wonderful to connect with you again. I miss our conversations from way back when. And thank you so much for your time.
If you could share some of that sun down here, we need some
Yeah.
now.
I know.
This is getting old, but we've gotten some rain here, but it's been really great to reconnect with you. I'm happy to help, however, and, best of luck to all that are on the call. And, thanks to all for really doing this difficult, grinding work on a day-to-day basis that is so very important to all people that unfortunately we've all had our share of back problems, hopefully limited back problems, but I think we're all at risk for that. So thanks for the team here of doing that work.
You're very welcome. And there's one last point I'll leave you with. We authored a paper on used Brinjiki's chart, where it was degenerative findings on the spine by decade in non-symptomatic people. And we published that work of how it actually lowered per member per month costs. And Matt was a co-author on that paper. I wanted to throw that in. And that's available on our website too to get that paper. So thank you all for joining us today. And thank you again, Matt. We'll be in touch,
Yeah.
I'm sure.
All right, take care, everyone.
Thanks, everybody.